Great, thank you very much. So acute GI bleeding in children is probably the last pediatric emergency where children are dying because of the lack of our skills rather than because of the severity of the disease itself. And that's partly because of lack of recognition of when to do an endoscopy, partly because the skill base to do these techniques is not particularly widespread, and also because there aren't that many of them, so people don't get practiced. So really there isn't any excuse for this to be occurring in modern times. And we do need to think, and this is Dr. Belcher, myself, publishing in the Journal of Pediatric Surgery about GI bleeding. And why is it such a poor outcome in certain circumstances? And the reason for that is up here. Because of lack of recognition of the severity of a bleed, perhaps, because poor knowledge of what's supposed to be happening before endoscopy and when to do endoscopy. Those are the main factors. And the key questions, if a child comes into your A&E department, ED, what is your immediate clinical response? When should we be scoping, and who should be doing it? So this is a 50-month-old female tetralogy fellow who had repair at 3 months of age. She presented to the local hospital early in the morning with a large hematemesis and then subsequently a melena. Hemoglobin was 57 and clotting was normal. So she was tachypneic. As we heard the previous session, she became tachycardic because that's how they respond to hypovolemia. And she had a splenomegaly. And there were also some angiomatous lesions on the abdomen. So what is your ideal management? You're going to call your senior doctor on call, risk annoying them. Are you going to resuscitate with fluid, start oral PPI, place a zinc stack and tube, or are you going to do E, ABC, start octreotide, IV PPI, and transfuse if necessary? Well, the answer, of course, is E. Do all those things first. So that's what happened with this child. Passed an NG, transfused, started octreotide intravenously, an IV omeprazole, and chest X-ray was done. So why would we do a chest X-ray? For button battery, yeah. So if you don't look for a button battery, a child with acute hematemesis, you run the risk of the child dying. And these are terrible little objects that can dissolve through the esophagus into the aortic arch within 2 hours. And then, of course, you end up having a thoracotomy and problems. So what else should we do before endoscopy if the patient's bleeding excessively? Well, in the interest of speed, I would tell you that E is what we should be doing, increasing the octreotide and terlipressin to decrease splanchnic blood flow pressure. We know that if there's varices present, with a clot overlying the varix, then we need to be doing an endoscopy. And this is an example of a bleeding lesion in endoscopy. And the treatment of choice for this now is, after resuscitation, of course, variceal banding by endoscopy. And there is no place of injecting sclerosants. So this is a view of the esophagus with these columns of varices, in this case not actively bleeding, but you can see the cherry red spot there, so it's about to bleed. We suck in the varix into the preloaded device on the end of the endoscope, and then we turn a little knob on the endoscope to deliver this blue rubber band. And that's the best way to treat these in the acute situation. And also, we will carry on doing that every 1 to 3 months until the varices are ablated. In other words, a prophylactic regime. And that happened in this particular situation. However, the bleeding recurred 8 hours later. So what do we do now? Well, we think about re-scoping, and we also think about re-scoping before discharge in the high-risk patient. There are other measures to stop rebleeding. Apart from banding the varices, you may need to look for fundal varices, and here we see the endoscope coming through the esophagus into the stomach, and we're injecting the fundal varices with histoacryl glue. It's not so good to band these varices because in the fundus the bands will fall off and then the patient might get torrential bleeding. And there are other measures we can use. Beta blockers, well, there's some evidence in pediatrics that they can be prophylactic, and long-acting other measures, and then shunts. So what should be the timing of endoscopy? Well, you don't have to scope every child, but I'll come on to that. Really, you need to be having clinical stratification in all significant bleeds within 12 hours, probably. And there are a number of guidelines, but these guidelines so far are really only appropriate for adults. And we're in the process of writing the pediatric guidelines. So these scoring systems, as you can see, are not very relevant to children because they involve things like cardiac failure and presentation with syncope and so forth. So these are available. They're only really applicable to adults because of the different parameters in terms of biochemical, hematological, and physiological. So in order to look at this, we had a study, again, with my colleague, Dr. Belcher, who got together all the subjects in a 3-year period of 62 bleeding children, 69 episodes. And what we did was stratify them to Group A that required no endoscopic intervention when we did the endoscopy, and Group B where we did need to intervene. And then we looked at all of these to see if we could work out what the likelihood of a child requiring intervention was based on a number of parameters. And the scoring system, with some sophisticated statistics, indicated we could load these different things. So 1 point for each of these. Heart rate greater than 20 above the mean for age. Prolonged capillary refill was a higher loading. Hemoglobin drop of more than 20, and then management and resuscitation. So this produced a total score of 24. And when we took the two groups, the cutoff for 8 gave us these positive and negative predictive values for a need for intervention by endoscopy. And here we see the purple squares, which are the ones that didn't need scoping intervention, and the ones above the line, the intervention group, who did. And that was a very nice piece of work. So that intervention is particularly important if they needed transfusion, if they'd had a hematemesis or melena, or if they dropped the hemoglobin, or if the initial hemoglobin was below 80. And then if they had a relative tachycardia. And this has now been prospectively validated. So what are the options to us? For those of you who don't do endoscopy, these are the things I'm going to show you for the next 2 or 3 minutes. And these are all via endoscopy. So this is a Mallory Weiss tear. And what we're doing here is putting a clip, an endo clip, hemostatic clip, onto the area of bleeding in order to try to prevent it continuing. Most Mallory Weiss tears don't need intervention, but this one did. So then we put this clip on, deploy it, and then you can see it's left in place and it just sloughs off in due course. And that's an animated version of the same of what you've just seen. This is particularly good for point bleeders, so arteries, arterioles like this. Again, it's very satisfying to place a clip on one of these and see it stop immediately. And this child, of course, was needing ongoing resuscitation. And then that's all that was needed. We can use electricity to cauterize areas. We can use argon plasma coagulation, particularly good for diffuse bleeding areas. And could you just move the presentation on one slide for me, please? It's just stalled. Thanks. Thank you. But this is the new thing, the Hemaspray, which is a powder that Cook make, and you spray it onto an area of interest, at which point, when it comes in contact with blood, it absorbs the blood and produces a cohesive adhesion mechanical barrier. And this makes life a lot easier because some of the techniques I've shown you are not particularly easy to perform. But with this technique, all you have to do is point and spray. And the hemospray is powered by carbon dioxide and produces this coating and can stop lots of different types of bleeding areas. Here we see an artery that's bleeding, and it's quite remarkable stuff. You just spray it on and it stops bleeding. And that means that the skill level for endoscopic management has suddenly dropped. You don't need to be able to do so many skills by endoscopy, you just have to point and press. And again, we published on this using comparative groups of standard hemostatic techniques versus hemospray, and it was very easy to see that it did actually do the trick there. You might have to move it on a slide for me, would you mind? Sorry, it's just stalled again. Thanks. There are a number of others, one's called Purostat, one's called Endoclot, but I'll not dwell on that. So the basic messages are, of course, we need to resuscitate, we need to decide which patient to do emergency endoscopy, we use IV octreotide and omeprazole, and think button battery, especially in a toddler. Usually urgent, i.e. within 2 hours endoscopy is not necessary, but usually within 12 hours it will be. And I'll just show you this last piece of technology, the over-the-scope clip. And here's it being deployed in a bleeding lesion. And it's pre-loaded tensile piece of machinery, which when placed onto an area of interest will spring into action, and it's very good for larger bleeders. And we've used it a few times at the Sheffield Children's Hospital now. So I hope we've answered these questions during this presentation, and I hope that you've taken away the initial management structure, which there's that endoscopy is performed if the threshold with those parameters is reached. But before endoscopy, we need to do all the other things necessary in the situation to stabilize a child prior to endoscopic intervention. And this is the guidelines that we wrote 4 years ago, and we would normally repeat endoscopy before discharge, especially if there's varices present. And just lastly, this is an episode of acute lower GI bleeding with angioectatic lesions. You can see bleeding in the colon. And this is a child who had a gastric duplication cyst that was eroding through from the stomach into the transverse colon. And this is a CT showing exactly that gastric duplication cyst here. And that was then eroding into the transverse colon and bleeding, and this child had a number of episodes where they nearly died. And that was the surgery for that particular circumstance. So, I'll just move on through this because time's getting on. It's really useful to learn to do these procedures without doing it in the emergency situation. So that's why we run all these courses with animal models and with hands-on intervention. And they are very useful. And I think I've been through that already, so we'll just move on. I'm happy to send this lecture to anybody who needs it at your discretion. And yes, and so this is where I live, in the Peak District near Sheffield, and you're very welcome to come and visit me, and I'm very grateful to Dr Sherif and his colleagues for inviting me to talk to you again. I very much enjoyed coming here. So, shukran. Mossad.
Thank you.